my presentation is on muscular dystrophy. Muscular dystrophy is a progressive genetic muscle disorder that is degenerative, and the etiology is based around the protein dystrophin. If you see this muscle picture breakdown, you can see where dystrophin is in every little muscle fiber, and it acts as a glue to hold the muscle together. In muscular dystrophy patients, dystrophin is not doing its job, therefore the muscle disintegrates and breaks down, and that open space is filled with kind of fatty, fibrous tissue, and once it's gone, it cannot come back. So that's why MD is considered degenerative. And each patient progresses differently over a different time period based on their age and which type of muscular dystrophy they have. Dystrophin is a large protein that stabilizes muscle fibers by forming a link between the cytoskeleton and the protein complex in the plasma membrane that connects the tissue and the extracellular matrix. Each type of muscular dystrophy is genetic, but different factors of the genetic process go into kind of which category they're going to fall into. So this is another great breakdown of the dystrophin example and how it is worked into every single muscle fiber. And if you go to the second picture, you can see over time, this is a great example of the age 5 to age 14, how much the muscle can break down in that time period. So because of the breakdown deterioration, a lot of these patients deal with muscle weakness, and they can work to sustain, but they're not going to get much back. There are 9 major types and 30 subtypes, and a lot more I feel that are unknown. I used to have a patient on my caseload whose diagnosis was in the family of muscular dystrophy, but didn't have a true title because they had never seen it before. She went to get muscle biopsies, I believe every 2 years, just because they were studying her muscle structure because they'd never seen it. So this is a big umbrella type diagnosis. And we'll go to the next slide. So these are the 9 major types of muscular dystrophy. Duchenne's and Becker are the main 2 that we see. They're both X-linked, so they pretty much only affect boys. And they present with obviously muscle weakness. Duchenne's, we'll see that enlarged calf. And because of those calves, we'll see an inability to run or jump as they should be at that age. Becker's will see the symmetrical muscle weakness, delayed walking, toe walking, difficulty navigating obstacles, and specific to Becker's is this heel cord contracture. Although contractures are seen in all of the MD types. And then as we get down this list, limb girdle, myotonic, fascioscapulohumeral, Dreyfus, congenital oculopharyngeal, and distal are all less prevalent than Duchenne's and Becker. Myotonic has another, or that has a bigger umbrella under it. There's, I believe, 30 different types under myotonic. And if we move to this next picture, we can see an example of some of the muscle areas that are affected, which kind of helps me understand the breakdown of what separates these diagnoses. So if we'll look on the left, Duchenne's and Becker pretty much affect the entire arms, pectorals, and upper legs. Dreyfus affects the upper arms and lower calves. Myotonic is a little bit all over the place, but more distal and extremities and into the neck and face. Fascioscapulohumeral is a little bit all over the place in the abs, arms, pecs, and face. Limb girdle is pretty much what it sounds like, affecting the limbs and the girdle area, and oculopharyngeal is based really in the face and the kind of oral motor areas. So I like these pictures as a breakdown. This was from the Muscular Dystrophy Association, and it was very helpful to kind of see, if you have one of these patients, where their breakdown is muscle-wise. Statistics of muscular dystrophy is often misdiagnosed because the prevalence, because there's anticipated lower prevalence because of the misdiagnosis, because of the onset of symptoms and crossover with other diagnoses. So this is a great example of my patient that I saw. She didn't even get the muscular dystrophy family diagnosis until she was probably 5 or so. She had a few random diagnoses before that. Thankfully, her mom is the special ed teacher, so she kept pushing because she knew that those diagnoses weren't quite right. So that's interesting to see a patient go through that process. It is seen across the globe in all races, genders, and ages. And as I said, Duchenne's and Becker's is the most prevalent. We see it in about 1 in 5,000, only affecting men now. Fascioscapulohumeral is about 1 in 15,000. Myotonic is about 1 in 8,000. Those numbers are directly from our book. If you look up statistics on the internet, you'll get all kinds of different numbers. I saw Duchenne's Becker's was 1 in 3,500 on another website. And the Muscular Dystrophy Association had a different website as well. But both this book and our book for the conditions class gave me that 1 in 5,000. So that's what we're going with. Method of diagnosis. These two gross motor kind of areas we can look at. The first one is called the valley sign. And you'll see this when you have your patient abduct both arms. You should see a divot almost under both shoulders, and that's just kind of where the first muscle degeneration starts. So that's a good test that pediatricians can do if this neurological condition is on their radar, or genetic condition, not neurological. And the bottom picture is called the Gowers maneuver. This is another test that doctors can do to see kind of a breakdown in motor coordination because of the muscle weakness in the legs. A lot of patients will get up with this kind of backwards walking, crawling up their legs pattern that is seen across a lot of Duchenne's Becker's patients. So this one is often used for kind of a red flag diagnosis. And then additional methods of diagnosis include blood tests, muscle biopsies, electromyographies, genetic testing, bone mineral density, and pulmonary function testing. That is such a wide range of diagnostic methods because those 9 different types affect different parts of the body. Muscle biopsy, I believe, is going to be the most effective because that dystrophin breakdown is going to be in each muscle or in each type. Even with my patient that I saw that didn't have the specific diagnosis, they're doing muscle biopsies every 2 years just to see how her muscles are changing and if it is degenerative or not. And treatment and prognosis. Treatment for muscular dystrophy is centered around a lot of education for the patient and family on what the diagnosis is and what they're going to face long term. It's not easy to treat patients with degenerative diseases. It's a mental health battle along with the physical, and they need a lot of support and encouragement. And so the main goal of OTPT speech is just preserving physical function as long as possible. We can do this with a lot of compensation or compensatory strategies with different positionings or different medical equipment. You can do some strength training and all that good stuff. But again, that muscle breakdown, once it's gone, it's not coming back. So teaching them how to work with what they got is where our job is going to focus. In some cases, corticosteroid therapy may delay the loss of the muscle strength, but I did read that they can deal with some complications from long-term steroid therapy, so it's not a great treatment long-term for these patients. Also, with some of the types of MD, cardiac and pulmonary complications present, so medical management for those symptoms will also be needed. Prognosis for muscular dystrophy really depends on the type and stage of the diagnosis. Just like a lot of diagnoses we see, there's a spectrum of where they're at, and some can have more mild symptoms and progress very slowly, and some have an onset and deteriorate very quickly. So really it just depends on how the person's body is reacting to that dystrophin breakdown. So treatment is really focused on just maintaining what they have left. Mobility is usually the main thing to go. And then depending on the type, the breakdown continues to happen distally or proximally. And these are my references.